Hi Ninja Nerds, in this video today we're going to be talking about urinary incontinence. So if you do like this video, make sure to give it a thumbs up, a comment down below, don't forget to subscribe, and then go over and check out ninjanerd.org. That's where all of our illustrations and notes for all the lectures we put up here on YouTube are available for you guys to check out and utilize, study from, and really just do your best there in school. But let's get started talking about urinary incontinence. So when we focus on this, urinary incontinence is when we have the inability to hold our urine, or we might be peeing a little bit, we're having some type of issue with urinating, okay? Specifically leaking. So what we're looking at here is we're going to talk about the micturition, meaning what is the problem for somebody that can hold their urine and then somebody who's not having the ability to hold their urine? Why are they going to the bathroom when maybe they shouldn't be or isn't appropriate? So let's go back and rewind a little bit and talk about what the micturition reflex is, because I think if you understand this, then understanding the different types of incontinence there are and why some people have issues with this is because of what's going on here. So micturition, what is it? So let's reorient ourselves here and look at our bladder, right, with its detrusor muscle around the outside that contracts in order for us to expel urine. And then we have our internal urethral sphincter, which is under involuntary control, meaning we don't control it. And then our external urethral sphincter, which has to do with voluntary control, right? And how does all this work? How do we essentially urinate? Well, when we're looking at our bladder here, our bladder starts to fill up, right? Maybe it's got 300 or 400 or 500 milliliters, right, of urine in it. So as we start to get urine, we start to get a stretch, right? As this bladder starts to stretch, we get little signals here, sensory signals that say, hey, our bladder's stretching. I think we might have to go to the bathroom. So we send signals right over here to our sacral micturition center. It's typically from S2 to S4. And it says, okay, we might have to pee here. So let's go ahead and start that process. So to start that process, what this does is it sends some motor over to our detrusor, right? And it says, detrusor, it's time for you to contract. All right, we gotta push out that urine, we gotta pee. So that happens, and we also have signal over here that goes to our internal urethral sphincter, and it says, relax. Please open up and relax, right? So that sphincter relaxes a little bit, opens up, and now we have the ability to possibly pee. But remember, this is under involuntary control. We still got one other hurdle to get through. We got the external urethral sphincter. So all this occurs, but there's also another message that occurs, right? So now we have a message that starts going up here, right? Travels all the way up to our pons. And our pons is the most unique of this whole situation. Our pons is basically our on and off switch between our pontine storage center and our pontine micturition center. Okay, let's back it up here for a second. We have our bladder starts to expand, right? It expands, it stretches, we get a receptor that says, hey, I think I gotta pee. That message goes out here to the sacral micturition center, and that says, okay, all right, we gotta activate some things here, so we're going to contract our detrusor, and we're also going to relax our internal urethral sphincter. I'm also going to send a message up there and talk to pons. Now, pons up there has two different centers. We have our pontine storage and our pontine micturition. If we have pontine storage on, what does that mean? We are going to store or hold, right, our urine. And our micturition means we're going to pee, right? Gonna let it go. So our pons, he's up there and he said, hey, I just got a signal from down below. We have to go pee, but it's not going to just say yes or no, let's pee. Send a message up here to our cerebral cortex. Our cerebral cortex says, all right, guys, can we pee right now? Is it time for us to pee? It's gonna say, no, they can't pee right now. We are in the middle of taking an exam. Like, we can't be just peeing right now. So it's gonna send a message back down to the pontine, or the pons. It's gonna activate the pontine storage center, and it's gonna say, no, do not relax. So then we will not relax our external urethral sphincter, right? Therefore, we are not peeing. But we finally later finish our exam, and it says, all right, guys, we're still sending this signal. Hey, can we pee up there? No, not yet. We're not in the bathroom. Hey, can we pee? No, not yet. We still can get our pants off. Hey, can we pee? And then eventually there comes a point where it's like, all right, we can pee. Turns our Pontine Micturition Center, eventually sends our signal all the way back down here to our external urethral sphincter. Tells us to relax as well, because remember, this is voluntary, right? And this is involuntary. And now, because we were able to relax our external urethral sphincter, that now opens up as well, and now we are able to urinate. We're going to urinate, we're going to empty our bladder, right? Not completely, but it gets pretty close. And now we are able to restart. We go back into eventually another signal that we're starting to stretch. Hey, can we pee? No, not yet. Hey, can we pee? It's not appropriate. Hey, can we pee? Yeah, maybe now. And then we go. Or we wait to the point where the bladder's so full that it's like, hey man, if you don't pee right now, like, oh no, we're gonna have a problem here. We're gonna probably pee our pants here. And this just goes on, signal after signal, check and balance. You know, are we turning on and off? Which one are we doing here? Storage, micturition, storage, micturition. And because of that, we are able to then urinate, right? We want to think about all the different links in here and the things that are occurring where we could have problems holding our urine, all right? Why would we all of a sudden just be peeing when we shouldn't be, or we're not storing it, we're just peeing? And that has to do with many different things, right? We have muscles. We talked about the internal external urethral sphincters, right? We have the detrusor muscle here around our bladder that contracts, so there could be trouble in there. Could be trouble with anything neuro, right? Anything within the spinal cord talking to our brain, that could be an issue. Could also be something that we didn't necessarily talk about here, but there could be some sort of blockage, right? Maybe there's a blockage here that's pressing our urethra, right, closed. And now we got this really tiny little spot for urine to get through, right? So all of these are issues with incontinence, but we have names for all of them. So let's go through and learn, or at least refresh ourselves of what those different types of incontinence are and what their typical symptoms and problems present like. When we talk about urge, we're going to be talking about overactive bladder, right? That's kind of like the term that you use to say to somebody, okay, you have overactive bladder, but typically it has to do with urge incontinence. And what that means is that this patient typically gets an urge, right? And then they essentially pee. And if we think back to the Micturition reflex, what we do know is that there's usually the checks and balances, right? There's the urge to pee, and then it goes up and talks to the pons and the cerebral cortex and says, like, should we pee, should we not pee? All that is occurring, right? But in this person's case, they have the urge, and then essentially they pee. They kind of just pee, right? And it could be emptying the whole bladder, it can be parts of it, and then they stop. What this has to do is that the bladder, essentially the muscle, is overactive. And there can be many different reasons as to why that occurs. There could be underlying issues. Maybe this patient has like a UTI, or they have something else going on with some type of medication that's giving them a side effect of this. But what is going on is that this detrusor muscle is having some type of dysfunction, right? Or it's just going at its own time. So you can even think of people who have bladder spasms, right? They have that quivering, that bladder spasm that is causing them to urinate, right? So this patient will come in and they're gonna say, oh, I've just been like peeing more often, or every once in a while, I'm just like peeing my pants, and I don't mean to, but I'll just like pee. And then I'll stop, but like I'm already basically halfway empty, okay? So that can be the urge problem. And then we can go over to stress. And when we talk about stress, this is a little more predominant in women, all right? So when we talk, let's get purple here. So stress has to do with increased abdominal pressure. When we have increased abdominal pressure, we have more pressure on the bladder. And we say that this is more typical in females, specifically because they've either had a baby vaginally, so they've had a vaginal delivery. All right, they're pregnant now. Okay, and one other thing with women is we have a shorter urethra, So because of this, what happens is we have that increase in abdominal pressure. So the increase in the ab pressure causes an increase in the bladder, right? So now we have increased bladder pressure. And then essentially, we only have, remember for the Micturition, we only have one other door that's basically shut because we already have our internal urethral sphincter has opened up. Our detrusor muscle is now starting to squeeze and contract. And now all we have left is our external urethral sphincter. So our external urethral sphincter is the only thing that's closed. Well, if it's weak from a vaginal delivery, right, or if they're pregnant now and there's so much pressure that this bladder pressure just overrides that ability to keep closed, and eventually we pee, right? So the bladder pressure is essentially greater than our external urethral sphincter, okay? So this patient, they have all these issues maybe going on. Maybe they're also having a problem where they're like, every time I sneeze or cough, like a little urine squeaks out. So they're having a little bit of leaking, okay? So their complaint is usually leaking a little bit, and they're having issues even maybe when they're lifting weights a little bit, it's leaking out. And it has to do with that pelvic floor being, gone through trauma of a vaginal delivery. We've squeezed out a baby, and now those muscles down there are having some issues. So what we need to do is to think about what is some of the problems that this patient needs. Well, if they are pregnant now and they deliver that baby won't be pressing on the bladder as much anymore. So that just might relieve all the problems here. But you also want to think about possibly the vaginal delivery having issues with the pelvic floor. Maybe those muscles need to be tightened or worked on. Or if it's a long-term problem, that they may have to have something else done, but we will talk about that later. But overall, what's the most important thing about stress incontinence is there's that increase on abdominal pressure, right? Maybe we got something going on. Maybe it was just a one-time thing. You have a really full bladder, and then all of a sudden someone threw like a basketball at you and boom, hit you in the belly and you peed a little bit. It all has to do with that increased bladder pressure being greater than that external urethral sphincter, right? It's just enough to push out a little bit. We still have tone, but not as good maybe, or it's just not enough that can withstand the bladder pressure, okay? Now let's move into overflow. So when we talk about overflow, this is our underactive bladder. So you'll notice right here in this picture, our bladder muscle right here, our detrusor muscle is very, very thin, right? Or it's not as strong as the other ones that we've been drawing. So what happens with underactive bladder? Maybe you have a weaker detrusor muscle, right? So that's one issue. Something's going on with the muscle, so it's going to be having an issue emptying. Could also have an issue emptying because maybe we have something enlarged over here, right? So this could be something like a prostate that's kind of blocking the opening. And it's causing that stream to have to come through a much smaller opening, okay? So there could be a decrease in the urethra. So the urethra, RA, diameter has decreased, or maybe there's a blockage. You could also use the word blockage. So this patient's gonna come in and they're gonna say, I don't know, I'm not necessarily having trouble peeing, but like when I go to pee, it's coming out real weak, or it just takes a while for it to start. Like I'm there for like 30 seconds until like the stream really starts up, okay? So we could say a weak stream. They could say delayed, right? Or we can even go into the word, they usually say dribble. It's dribbling out of me. It's barely even coming out, right? So all this has to do is essentially there might be an issue with a blockage, right? Something that's blocking the opening, or there's a weakness within this bladder, and we need to assess that and go into that for our patients. Now those are the three you're gonna see most of the time, but there is also one that we can talk about really quickly, super easy to remember, is the mixed. And what that has to do is that there could be somebody who is pregnant, but also has a UTI, right? So they are pregnant, meaning they're going to have our stress incontinence, but then they also have now developed a UTI, so now they're also going to have urge incontinence, right? So mixed is essentially just talking about there can be a couple, more than one issue going on with this patient. And then functional. Functional is one that we don't talk about often, but it is one that we need to touch on. So when we talk about functional, we're talking about essentially our patient having the ability to urinate normally, but they have something functionally wrong. So meaning there's either some type of cognitive issue. So what I'm saying is that the detrusor muscle is able to contract, the sphincters are working normally, but cognitively they don't quite understand what's going on. They could have some barrier. Okay, what that means is I think of this as like mobility. And you can think about this even further, like arthritis. So a patient has trouble getting to the bathroom because they're using a walker, they have trouble with dexterity. So this functional group, they have cognitive barriers, they could have barriers with mobility, arthritis. What we're looking at here is somebody who is either really young, right, or somebody who is older, like our geriatric patients. And this has to do with maybe they had a stroke in the past, they just can't quite get the concept down again, or they're really young and they know they have to pee, like, you know, they're 5, 6, 7 years old and they're like, I gotta pee, but they played outside for too long and then they go to like run inside and they have to get through a door and then they have to get their pants down and they just waited too long and they pee by the time they get their pants off. So functional just has to do with necessarily everything inside's working to its normal state as it could. The muscles are doing okay, but the patient's having trouble with arthritis or mobility. The patient's having trouble just quite understanding maybe the timing that they need, right? So when we think about this, I want you to think about children and the geriatrics, right? So we got our pediatrics and our geriatrics typically in this group. So think about the patients in those groups. Think about some things that could be barriers for them as well. I always think of pants, like if you're wearing jeans or any type of pant that has like the buttons, not necessarily just a button and a zipper, but buttons all the way down. Just think about how hard that might be for somebody who's having trouble with dexterity, right? They're not able to get all these snaps and these buttons off as fast as they could. So typically, geriatrics and pediatrics are wearing those elastic waistband pants, right? You just stretch them right off and then you can go to the bathroom. A lot easier and a lot more elimination and the difficulty of getting your pants off, so then hopefully we can get to the bathroom in a safer amount of time and urinate in the bathroom. So now we're going to talk about quickly all the signs, symptoms, treatments, and how we just basically assess and work with a patient who maybe has a type of incontinence that we're not quite sure how to deal with, or we don't know the severity of it yet, but we do want to start taking care of that patient now at the bedside. How do we do that? Some of the signs and symptoms of incontinence might not be very, very apparent as to what type of urinary incontinence a patient has. But I want to just touch on, say you're getting a new patient, you don't really know much about them, we're still kind of investigating, trying to see what our plan of treatment is going to be for them. So what I just specifically want you to look at is maybe you're getting an exam and they're throwing all this stuff at you and you got to kind of figure out what's going on with the patient. So our patients that do have some type of incontinence or typical things that might lead you down the mind track of thinking, this patient I think has urinary incontinence and I think it's this type. So let's back it up. What are some of the complaints that they have? They're going to say, oh, when I cough, I, pee a little bit, I leak a little bit. So we can say cough or sneeze, I'm leaking a little bit, right? Or we can say got nocturia, right? Or a patient says, I keep going to, every time I go to sleep, I have to wake up in the middle of the night, go pee. That always happens. Patient maybe has a dribble or a weak stream, right? Not as much as coming out or as forceful as I feel like it should. Sometimes I get the urge to pee and I just I wet my pants a little, I wet more than I should, right? And it's getting embarrassing. So then we want to start thinking about the social and emotional issues. Maybe they're not really worried about the urinating per se, but they're saying, well, I don't really want to go places now that this is happening, or I think I smell like urine every time I go places. So that's also a problem. What are some other things that could be going on with these patients? They're maybe going to the bathroom frequently because they're having something else going on. They could be having those bladder spasms where they're saying, it's a little actually painful that I have this squeezing in my bladder. It feels weird, okay? And when we start thinking about these common symptoms, I'm going to the bathroom more often, it's feeling weak, I'm peeing a little bit, peeing more than I should, we start to think about, okay, this patient maybe has some type of incontinence. So we go in to assess them further, right? And we start thinking about our tests and our assessments. So we're going to be asking them things like, do you have a urine journal? Have you been keeping track? Is this something that your doctor has said, you should start logging what's going on with your urine? We also want to look into their medical history, right? Do they have something that is maybe going to tell us what's going on? Do they have a new medication that they started? Are they currently pregnant, or they just found out, it's their first pregnancy? Is there some type of surgery that they got in the past that potentially could have caused some type of issue down below with nerve and muscle response, right, in the pelvic floor? Did they have birth to a baby, And then we can also say a urinalysis, right? We want to always check the urine analysis. And then do our screenings of, is there any pain? Are you having any fevers? Does the urine smell funny? And then if they are having incontinence or issues with going to the bathroom, we also sometimes want to investigate what we call a post-void residual, right? And this isn't specifically to a patient that has incontinence, but somebody who is having issues maybe going to the bathroom. Specifically the ones that are saying, it feels weak, my urine stream feels weak, or I'm having trouble with it initiating. Because what we're essentially starting to think is there a problem with eliminating what's in the bladder? So what is a post-void residual? Post-void residual is our patient starts to accumulate urine, right? So urine is accumulating in the bladder, and we get the urge maybe to go to the bathroom. What was that number? It's usually greater than 250. So anywhere greater than 250 milliliters is when we start to maybe get the urge, okay, I think I might have to go to the bathroom, or I could pee before we leave. So when we go to do the post-void residual, patient's laying flat, we take our little bladder scanner, you can do it right at the bedside, super easy, put some of the gel on them, and we're able to basically use a little ultrasound machine to see what's going on in the bladder. It'll scan the bladder and say it said it was 800 in there, right? So we have 800 milliliters in our bladder. You can ask the patient, do you feel like you need to go to the bathroom? If they say no, that's a part of our assessment. If they say yes, okay, great. So we're starting to log this information in. Then the patient goes to the bathroom. When they go to the bathroom, we want to make sure we give them something that can measure, right? So we want to make sure we're able to measure it, whether it's a hat, a colander, anything like that we're able to take an accurate measurement in milliliters of how much urine the patient has expelled. They're going to come back into the room and lay back down on the bed, and then we're going to measure them again, right? So this is then the post-void residual, right? How do we do that? Say in the urine here, we have, I don't know, this is a lot of space because we don't have that much urine left. So say maybe there's only 300 left, right? Okay. So patient voided 500. What's left after urinating was 300, okay? We want to make sure all those numbers add up when we do this. So the patient, we got the urine that came out 500. So when I bladder scan them, there should be around 300. I bladder scan them, okay, 300 is left. Okay, that makes sense. Why is this important? Why is the post-void residual a good assessment for us to use, a good tool that we can use for our patient? It's telling us, one, if our patient's emptying their bladder, right? So this patient is obviously not adequately emptying their bladder. Now, is this going on for any particular reason? Are they having an enlarged prostate? Do they have a weakened detrusor muscle? What's going on with them? Or is there something else going on? Maybe there's an infection. We don't know yet. That's why we're getting that urine analysis. But it's also going to tell us if they had an issue before, like, do they even know they have to pee here? This patient said, no, I don't, 800 milliliters. Like, you're scanning their bladder and you're like, yeah, 800, you're looking at it, you're not saying it, but you're like, 800, okay. You're scanning and you're like, do you have to pee? And they're saying, no, I don't have to pee. And you're like, well, this is the point when you should, because your bladder's almost completely full, like, So we want to start thinking about post-void residual. This is going to point us into the realm of what kind of incontinence. Right? Overflow incontinence. We're not emptying our bladder as far as we maybe should. We're having some type of issue with our stream. So there might be a blockage or an issue with our muscle, like our contraction. So that's another thing to think about, right? And then the last thing we want to think about too when we go through is this patient had any type of neuro deficits, because that's where some of this could come to. Is there any type of neuro issue going on with this patient? Do they have spinal cord injury, stroke, things that would point us down the line of, okay, this patient has issues neurologically, and this might be affected from it, our ability to go to the bathroom. Once we do assess them and maybe get down to the point where we're like, I think I even know what type of urinary incontinence they might have. Remember, we don't diagnose, we just, take care of the patients, intervene, and get them as best as we can. We start to go into our nursing interventions. And the nursing interventions are very similar for patients with incontinence because the whole goal of them is to keep them first dry and clean, okay? This is really important because the patient's urine, well, anybody's urine, is an irritant to the skin, and that can cause skin breakdown, right? And if this patient's having incontinence along with mobility issues, then we're going to be sitting in our urine longer. It has that risk for injury, risk for breakdown, skin breakdown, risk for skin ulcers, so anything like that. So the biggest thing with the nursing interventions is first, let's keep them dry, let's keep them clean. How do we keep them dry and clean? One of the big ways is to get them on a schedule, right? So we're going to get them on a schedule, one, to go to the bathroom, but two, just to be going in for changes and stuff and checks. We want to make sure that we are able to note that they are peeing, because some patients know they have incontinence and they can feel that they're wet. Some patients don't know they have incontinence and they're also don't know that they're wet. So they're just going to sit there and say, you're going to say, oh, Ethel, did you pee? And she's going to say, no, I didn't pee, I'm dry. And then you go down there and you're like, okay, there's a lot of pee down here, so Ethel, we got to get you changed up. So dry and clean, and also a schedule. Wake up in the morning, let's go pee. Go to eat breakfast and then go pee. Continue on with the schedule, continue on with the cleaning and changing. Another thing, what goes in must come out. So we got to think about our I's and O's, right? What is our daily fluid intake for this patient? Are they on some type of restriction because they have any type of medication going on, some type of underlying condition that we're treating as well? We also want to think about when that intake is occurring. Are they only on 1,200 milliliters of fluid a day, and they're drinking 1,000 at 6 p.m.? Throughout the rest of the day, they only drank 200. That's also going to cause us some issues with going to the bathroom at night. We also want to start thinking about anything that we can do for them emotionally and social, right? So we want to be able to empower our patients emotionally and socially. Being able to, talk to them and say, okay, you have urinary incontinence right now because you're pregnant, okay? The baby's pressing down onto the bladder is causing that increase in pressure, and you're having these little leaks of urine. Well, once you give birth to baby and you can strengthen up those pelvic floor muscles, then we're gonna have better outcomes, right? That incontinence has a potential to go away. So we're gonna try to empower our patients by giving them a reality of the situation, but in a way to say, but in the meantime, we can give you X, Y, and Z interventions. We can give you pads, go to the bathroom more often as we can. I'm here to help you, so ring the bell, I'll come in and get you, and we'll go to the bathroom together. And eventually, hopefully gain a little bit of that power, a little bit of independence back, right? Think of that Maslow's hierarchy of needs. We want them to be feeling independent and social and emotional, all that to be in a nice balance. The last thing that we're going to do is talk about treatment. So notice when we talk about treatment, we don't mention the one thing that they will always put on an exam, okay? And I'm not even going to say it here until the end because I don't want you to start thinking about it. So when we talk about treatment and education, the first thing we like to always think about with the treatment is that we're going to do the least invasive first, right? We don't want to go in and immediately say, oh, well, it's time for a permanent catheter because that's it for you. No, we're going to do a least invasive. So what does that mean? Things that we can do that are least invasive for the patient. They're going to learn to get strength in those muscles. What could those be? Those could be the Kegel or pelvic floor. Training, getting that all nice and strong. We want to also think about avoiding coffee, alcohol, because all those have what effect in our bodies? What does coffee and alcohol do? Remember, when you drink, especially alcohol, and you drink a lot of it, it has a factor that affects the antidiuretic hormone. Antidiuretic is the anti-diurese, right? Stop urinating. So what this does is this decreases ADH, antidiuretic hormone. If it decreases the stop peeing or don't pee hormone, now what are you going to do? You're going to pee more often. If you're peeing more often, you have more of a chance to urinate, right? Especially in your pants. So that's what we want to start thinking about here is what are other ways that we can help our patient? So avoid coffee, Kegel floor, pelvic floor exercises, gaining all that strength. We can also give them, again, referrals, right? Maybe when they do this Kegel pelvic floor training, they're going to physical therapy. So maybe there's other things that we need to train as well. Mobility to sit down on the toilet or to get our pants off with those buttons. That's really hard as well. And then we can move into more specific things if there's something down the line. Maybe they need to get their prostate removed or other types of medications to go on in order to treat some underlying conditions. Maybe we also need to just get them on a regimen of their fluids, right? Educating them about not drinking close to bedtime. And I'll put not drinking fluids just to clarify. You also want to think about pee before leaving the house. They can also just every 4 hours learn, okay, 4 hours, you're going to go to the bathroom. Right? Whether you think you have to or not, just go. Maybe you did accumulate a lot, especially those that are having trouble sensing that their bladder is full. Right? And then the last thing they could do, if they haven't started already, is to keep a journal or keep a log, right, of what's going on for us. How can we educate them? We can educate them by keeping that journal, right? That way we're going to be able to even see what their schedule is like at home, especially when they're not in the hospital. All right, Ninja Nerds, I hope this made sense. I hope you learned and got some clarity on the different types of urinary incontinence that you can run into with your patients. And as always, until next time.